Welcome, everyone. It's the top of the hour, so we'll get started. I'm Dia Waguespack, and I'd like to welcome you to today's GlomCon seminar. Today, our talk is titled Denys-Drash Syndrome, and we're very excited to have our speaker, Dr. Ana Catalina Alvarez Elias.
So thank you very much for inviting me. For me, it's an honor, and I'm very flattered to be here presenting in front of all these experts from around the world. Today, I chose this topic because it is something that goes very deep in my heart. I think that all of us during our clinical practice, and mainly during our clinical training, there are some cases that really mark our life and really mark how we have our perspectives on how we want to move forward with our career. So I'm going to be today talking about, as it was said before, Denys-Drash syndrome, and somehow discussing the integrated molecular genetics with renal histopathology in pediatric nephrology. So the presentation is focused on a pediatric rare disease, and I would like to do some emphasis on how can we contribute and collaborate international to improve the care of our patients. These are my disclosures. So the objectives for the talk is understanding the genetic and molecular mechanisms that underlie Denys-Drash syndrome, correlate these with the histopathological renal features, review clinical presentation, diagnostics, treatment, prognosis, and the adult implications, highlight the innovative research and evolving treatment paradigms that are out there. So congenital nephrotic syndrome is a concept that we need to talk about, and I'm sure that in the audience we have plenty of pediatric nephrologists, but I'm aware that we also have adult nephrologists in the audience of GlomCon. So the congenital nephrotic syndrome is a rare genetic kidney disorder, which it has the features of the nephrotic syndrome with massive proteinuria, hypoalbuminemia, and edema, and is presenting within the first 3 months of life. And that's probably the most important feature, that it's really after birth when these patients are having this clinical presentation. 80% of this congenital nephrotic syndrome are cases that are associated to 5 main genetic variants, which are the NPHS1, NPHS2, WT1, LAMP2, and PLCE1, which is the phospholipase C epsilon. And we are gonna not go over all of them, but it's just to show that WT1 is one of the within the most common monogenic disorders that are affecting congenital nephrotic syndrome. So as we all know, the glomerular basement membrane is composed of the 3 layers that are the fenestrated endothelial cells, the glomerular basement membrane, and the visceral epithelial cells or podocytes. And the genetic pathogenic variants of kidney proteins are going to lead to congenital nephrotic syndrome of the different most common fat types that I mentioned. So for instance, the nephrin is going to be found at the slit diagram and connects the podocytes' food processes. The podocin is going to be a protein that is exclusively expressed in the podocytes and leads the plasma membrane to the actin cytoskeleton. And the WT1 is going to be in the transcription factor that is found in the podocyte nucleus. The laminin beta 2 is going to be a component of the glomerular basement membrane, and the phospholipase C epsilon is going to convert the phosphatidyl inositol 4,5 in biphosphonate into inositol 1,4,5 triphosphonate and the acylglycerol, which is involved in the cell signaling, growth, and differentiation of the cells. So let's start with the clinical case that I'm talking about. And as I said, this is something that really marked my life on how difficult it was to handle this patient. And this was a patient that we received at the Hospital Infantil de Mexico. I have been privileged that I have trained in 2 different worlds, which is Mexico City and Canada in Toronto. And I have also been privileged to see clinical practice in Guatemala, Central America, and the United States. So that has given me a broad perspective on the different access to healthcare technology and science that patients have in the different subsets that they need. So this is a baby boy that was 40 days after birth, male. It was phenotypically reported with undescended testicles and underdeveloped penis. The birth history was not very relevant, full-term baby, normal APGAR, no perinatal complications, and there was no family history of consanguinity and renal diseases or any other genitourinary anomalies. The chief complaint, the reason that the baby was transferred to our center, which is the tertiary center in Mexico Children's Hospital, was progressive generalized edema, reduced urine output, and failure to thrive since birth. The baby was not truly growing as per the mom. The mom also had low literacy, so it took a very long time for her to seek for medical health for several days, as she was not noticing the edema was too severe and not being too concerned about this progressive edema. On the physical exam, the patient was coming already in anasarca, hypotonia, and ambiguous genitalia. The baby has clitoromegaly and absent of palpable gonads. The blood pressure was 105/68, which was not too high for a neonate, but in the threshold of being high blood pressure. The weight was below the third percentile for the age, and this was estimated, calculating the excess of fluid that the patient was having, and the baby has no dysmorphic features. On the investigations, the serum albumin was 1.7, urine analysis with 4 plus of protein with no other relevant aspects on the sediment. The urine albumin to creatinine ratio was 3.2 milligram per milligram, and in a urine collection of 24 hours, the patient was catheterized. We had 63 milligrams per meter square per hour. The serum creatinine was high for a neonate or a baby on that age, 1.3 milligrams per deciliter, and the karyotype was corresponding to a male, 46XY. The renal ultrasound showed bilaterally enlarged echogenic kidneys, but no masses or any suspicious of Wilms tumor. So with those aspects, we have a starting diagnosis of congenital nephrotic syndrome, and because of the ambiguous genitalia and the